In the earlier session, we have seen the detailed gross features of the ovary. So in this session, we'll be studying the gross anatomy of the uterine tube. And again, in this class, there is no topic which is discussed in relation to the histology of uterine tube because that is a separate lecture which will be given separately. So uterine tubes, also called as fallopian tube or oviduct, which convey the ovum from ovary to the uterus or uterine cavity. It is approximately 4 inches or 10 centimeters long, situated in medial 3/4 of upper margin of the broad ligament, conveys over from ovary to uterus. How these tubes are conveying? That is facilitated by the longitudinal grooves on ovarian fimbria, which is also lined by ciliated epithelium, and the beads of the cilia and the peristalsis of the tubal musculature. So if we see in a condition called immotile cilia syndrome, ciliary beating current is absent. The ova are conveyed completely by the action of peristalsis of the tubal musculature. Course: the uterine tube passes laterally from lateral angles of body of uterus, reaches uterine end of ovary, passes upwards along the mesovarian border, otherwise called the anterior border, then arches backwards along the tubal end of ovary, and finally turns downwards and comes in contact with the posterior border and medial surface of the ovary. You can see here. So it passes laterally, reaches the ovarian end, then ascends upwards along the mesovarian border, then arches backwards in relation to the tubal end of the ovary, then descends downwards and reaches the posterior border and medial surface of the ovary. You can see here also the relationship of the fallopian tube with the ovary. Presenting parts. There are two openings which are called as ostia, uterine ostium and the pelvic or abdominal ostium. Uterine ostium approximately 1 millimeter in diameter. So it is the point where intramural part of the ovarian tube opens into the uterine cavity. Pelvic ostium 3 millimeter in diameter, lies at bottom of the infundibular part of the uterine tube, where this pierces the posterior layer of broad ligament and opens into the pelvic cavity. So peritoneal cavity in women is open. The margins of this pelvic ostium presents fimbria. So one fimbria is larger and is attached to the tubal end of the ovary called ovarian fimbria. So that's why this end is also called as fimbriated end. You can see here, this is the uterine ostium, this is the abdominal ostium. You can also see the fimbria here. There are 4 parts from medial to lateral. From medial to lateral, if you see, the first part is the intramural part, otherwise called as pars uterina tubae, 1 centimeter, traverses the uterine musculature at the junction of body and fundus. So it is the pars uterina tubae. One centimeter length, traverses the uterine musculature at the junction of body and fundus. Isthmus, the intramural part, after exiting the uterine musculature, continues as the isthmus, which is cord-like. Why this is cord-like? Because the wall of this particular part of the uterine tube is thicker than the lumen. It is approximately 3 centimeters long. The continuation of isthmus is the ampulla, 5 centimeters long, most dilated part, and fertilization takes place here, and even ectopic pregnancy lies in the ampulla. So ectopic pregnancy is pregnancy outside the uterine cavity. The most commonest location is the ampulla of the uterine tube. infundibulum. It is lateralmost part, 1 centimeter, presents polycostium and fimbria as described earlier. And close to this end, there will be certain pedunculated vesicles attached to fimbria. These are called as appendices vesiculosae, otherwise called hydrates of Morgagni. You can see here, this is the intramural part, uterine ostium, intramural part continuing as the thick cord-like isthmus, then the most dilated part, the ampulla, and the last part, the infundibulum, at the bottom of which there is abdominal ostium or the pelvic ostium, and you can also see the fimbria. Relations of the uterine tube. Below, there is anastomosis of uterine and ovarian vessels. Below and in front, round ligament of uterus. Below and behind, ligament of ovary with the ovary. You can see here, below and in front, the round ligament of uterus. Below and behind, the ligament of ovary with the ovary. You can also see the ovarian fimbria here. And exactly below, you can see the anastomosis between the uterine artery and the ovarian artery. Here you can see below and in front the round ligament, below and behind the ligament of ovary. Arterial supply, ovarian artery which is branched from abdominal aorta, uterine artery which is branched from internal iliac artery antidivision, venous drainage, ovarian veins and uterine veins, lymphatic drainage, pre-aortic lymph nodes and lateral aortic lymph nodes. The lymphatics which are reaching these nodes, they are following the ovarian vessels. The intramural part drains into the superficial inguinal lymph nodes. So these lymphatics follow the round ligament of uterus. Nerve supply, the sympathetic peak ganglionic fibers comes from T10 to L2. They pass through the ovarian and superior hypogastric plexus to reach the uterine tube. Parasympathetic, the lateral part of the tube is supplied by the vagus and the medial part is supplied by the pelvic splanchnic nerves. You can see the dye is introduced into the uterine cavity, and you can see the dye is being traced through the uterine tube and it is spilling into the pelvic cavity. That means the entire female tract, reproductive tract, is intact. There is no closure of the uterine tube due to any kind of pathology. So this is a normal hysterosalpingogram. Here you can see the hysterosalpingogram which is identifying the bicornuate uterus. So ectopic pregnancy, normally the pregnancy should occur within the uterine cavity. So if the pregnancy continues anywhere outside the uterine cavity, that is called as ectopic pregnancy. The most commonest site is the ampulla of the uterine tube. The most important complication of the tubal pregnancy is the ruptured ectopic, which is an acute emergency. Symptoms will be sudden severe abdominal or pelvic pain, dizziness and fainting, pain in the shoulders also due to leakage of blood into the abdomen affecting the diaphragm, so pain in the lower back. So any early trimester pregnancy, if you find these symptoms, immediately rush to the hospital and get a scan done to observe for ruptured ectopic. And one physiological feature is the HCG levels will be very low in ectopic pregnancy. Tubectomy. So this is the female sterilization procedure. The counterpart of it in males is a vasectomy. So usually if you observe, if it is the second pregnancy and if they are doing a cesarean section, usually the obstetrician and gynecologist, they also take consent for concurrent tubectomy. You can see the tubal ends are cut and ligated. So this is the laparoscopic approach for the tubectomy. Thank you.